Hello, hello. Happy Friday, everybody. Welcome to VMR number 1100 something. It's crazy. I'm gonna do this countdown now, by the way, or count up. Um, which makes it even more, it keeps the pressure alive to never stop counting, hopefully, fingers crossed. Um, I am a little sad that I will be hogging the discussant stage today because Prof. Res can't join us today. He's with his family on his way to Manhattan driving right now. And so cannot join. We'll miss him deeply. And so to fill his void, the only way we can do so is by huddling all together. And so I'll share, I will try to represent our and our thinking as we normally do, but we'll create some space and time for breakout rooms so that you all hang out with each other. So um, a it's wow. Okay. All right. We got this goes to show you the kind of amazing people we have around in the academy who know exactly the number. Thank you guys. 1163. Crazy. 1163. Oh my gosh. Nuts. Anyway, hopefully we'll get to 10,063. Um, we again are lucky enough to have an Academy member who is presenting a case today. Now, Preet, I'll pass the mic to you to tell the crowd a little bit about yourself, and then we can jump right in.
So, hello everybody. So good to see all of you here. So my name is Navpreet. I'm an international graduate from India, and right now I'm in Tampa, Florida, and applying for internal medicine residency. And so excited to be here presenting a case today.
Preet, I got to chat with Preet for a glorious hour 2 weeks ago, and learned a lot about you outside of medicine. What's one thing you want to share about yourself here?
A lot of things actually, but yeah, outside of medicine, I love cooking some different cuisines, hosting friends over the dinner. Other than that, I love fishing, and that's pretty much all.
You should know that Napreet does not like to cook anything traditional and likes to be a creative cook. So if you ask him to cook something routine and boring, he'll probably yawn. But if you ask him to be creative, I'm sure he'll
Oh yeah.
deliver. Um, anyway, I wonder if your cooking skills are like your case skills, or whether we're dealing with a routine or we'll have some esoteria spicy combo today. But I'll pass the mic to you to tell us the story.
Okay, let's start the case. So I'll start with my first aliquot. So today we have a 26-year-old female who present to the hospital with a complaint of bilateral lower extremity and upper extremity weakness. And I'll stop.
I think this is a really, really important space to reflect on. And I think that the first question that comes in people's minds is the word weakness is the patient's core concern. And I think whenever we hear weakness, we jump into the neurological category. But I think, especially with the English language, you have to be careful that weakness isn't being used to convey a sense of fatigue or a reduction in energy. And in the subsequent history of present illness, what we're going to try to establish is, has the patient had a drop in energy, or is she dropping things that she can't hold, or dropping herself and falling? And trying to establish what is dropping energy or objects, including the patient themselves falling, is key to try to figuring out, are you dealing with a neurological cause, or are you dealing with what the medical term is asthenia, a sense of fatigue or weakness? The most powerful feature to help you distinguish between weakness representing asthenia, i.e., a sense of fatigue, or weakness representing a neurological issue is the physical exam. Asthenia um, is just to tell you, Tansu, it's with an A. I'm probably pronouncing it incorrectly, but it's AS. Yeah, there you go. Uh, Asthenia is, I'm feeling really, really fatigued, but I have no neurological weakness. And so the exam will help you establish that. But often you do a quick conversation with the patient, and I will tell you that the following things predict a neurological cause of weakness. The first is that there's any evidence of focality. If there's focal weakness, it's neurological in nature. If there is accompanying sensory, accompanying autonomic, or accompanying cognitive concerns, the patient likely has neurological weakness. And here's one really, really cool thing I want you to all study. anorexia. Anorexia is an incredibly unusual feature of neurological disease and strongly supports asthenia, a sense of fatigue. Most people who are run down and fatigued will also have a reduction in their appetite. So if we're making a table now of neurologic weakness versus asthenia, the exam is the gold standard. What are predictors of neurological weakness? Focality, the presence of sensory, cognitive, or autonomic symptoms, and the absence of asthenia, i.e., the presence of a normal appetite. What would favor asthenia is a lack of focality. The whole body is weak or fatigued. There are no sensory symptoms, no cognitive symptoms, no autonomic symptoms, and the presence of anorexia or a reduction in appetite. Let's apply this rule to just a few words that we've heard. It may seem that this patient does not have focality, but she does. The focality here is that it is sparing the face. This patient is having weakness in her arms and legs without involvement of her face, strongly arguing against asthenia and pushing forward the crux to, let me close this because they're doing some work out there, pushing the case towards neurological weakness. Whenever somebody has such extensive neurological weakness, instead of localizing the lesion, you have to think about morbidity. And the key thing here is to first establish, is there respiratory involvement in this patient? So what would I do? I would have the conversation to help me figure out asthenia versus fatigue. Then I would do the neurological exam, but I would pay special attention to neck flexion, neck extension as a proxy of whether the patient also has respiratory involvement in a case with such extensive neurologic manifestations. All right, Narpreet, I'll pass the mic to you.
Thank you, Ravi. It's an amazing starting discussion. And in this aliquot, I'll give the HPI as well as past medical history. So, a patient complains of bilateral lower extremity pain, numbness, and weakness since 1 month. Along with that, patient started complaining of bilateral upper extremity weakness since 15 days. On hospital visit, patient was unable to walk. She was using wheelchair for walking since 1 week. Along with these symptoms, patient have associated symptoms of intermittent perioral numbness since 3 months, intermittent nausea, vomiting, and poor appetite since 2 months, progressive bilateral hearing impairment since 1 month, and patient has a weight loss of 40 pounds in last 5 months. Past medical history, patient have a history of anxiety, Lyme disease treated 10 years ago, and hypertension. Patient has a positive family history of hypertension in the father, and patient had a ear wax de-impaction procedure done 1 month ago. Talking about personal and social history, patient do not have any pets. Patient smoke cannabis, lives with his boyfriend, and she has one sexual partner since 6 years. Medication, she is taking lisinopril 10 milligram QID, Zofran 4 milligram PRN, and gabapentin 3 milligram TID. Patient do not have allergies, and I will stop here.
Automatically, I think, Narpreet, you're painting a story that is very, very alarming for many reasons, including the extent of the disease involved and the consequences of it. And there are two key consequences. The first is the patient has lost the ability to do something so fundamentally important, which is to walk. And the patient has lost something even more fundamental, her body mass. And both those things are markedly red flag symptoms that push the momentum of this case hurtling forward. As is true for any schema, when you try to divide things into this or this, you're open to the to narrowing too soon and forgetting that you could have an and between those two processes. And I think what you're showing us actually is a case of both neurological weakness and asthenia, in that the patient is both having a prominent neurological dimension, but also a weight loss dimension and down that asthenia arm. So now we have to try to find a scenario that explains both, but we're probably going to make progress by first analyzing each thing independently. And so here, the weight loss has to be analyzed in the systematic and rigorous manner that we do by wondering first, is there inflammatory weight loss? Or is this non-inflammatory weight loss? Inflammatory weight loss referring to weight loss as a result of a chronic infection, a chronic autoimmune disease, or a malignancy. Non-inflammatory weight loss is a simple calculation of calories not making it into the blood, either because the patient is malnourished, because they don't have access to food or a desire to eat because they're depressed, or it hurts when they eat because they have dental issues. So malnourishment, malabsorption, or the effects of medications like bupropion, which he does not have. So if you're thinking simply about non-inflammatory weight loss, we'll really have to track, is she not getting calories in? Is she not absorbing them? Or is she having a medication or an endocrine process interfere with that process? If you try to ask yourself, how does weight loss overlap with neurological disease? And both inflammatory causes of weight loss can induce, for example, a paraneoplastic neurologic condition, but also the impaired caloric intake causes are prominently associated with nutritional deficiencies such as thiamine or B12 that can cause neurological consequences. So both sides of the weight loss world, inflammatory and non-inflammatory, can be almost effortlessly linked with neurological conditions. So you can't make much progress on that alone. So let's study the neurological dimensions. And the first thing we hear is the patient has a sensory component to her symptoms. And what that does is it effectively eliminates the possibility of a myopathy. What's also much less likely is the exact polar opposite of the neuraxis, which is the brain. The brain is less likely because she has such prominent symmetric symptoms without any cognitive concerns. So you can eliminate the extremes of the neuroaxis based on the presence of sensory symptoms to make myopathy less likely, and the absence of cognitive symptoms to make the brain less likely. Everything in between is totally fair game. She has perioral symptoms, so the brainstem could be involved, and she has upper and lower extremity involvement, so the cord could be involved, the nerves can be involved for sure, as can the presynaptic neuromuscular junction. The other thing that's excluded is the postsynaptic neuromuscular junction, namely myasthenia gravis, is not at play because patients with myasthenia gravis do not have any sensory symptoms. So to summarize, the brain is almost gone because there's no cognitive symptoms. And the muscle and the neuromuscular junction, the postsynaptic neuromuscular junction, are gone because the patient has sensory symptoms. But everything in between is fair game. So how do we make progress from there? I think that's where the value of urinary and bowel symptoms is really, really handy. Most patients with a cord problem will have autonomic symptoms in their bowel or bladder. And the absence of those reduces the probability, but does not eliminate the probability of a myelopathy. So we might be invoking a, I think the most precise localization is to wonder about a diffuse peripheral nerve problem or a presynaptic neuromuscular junction problem, such as Lambert-Eaton syndrome. But I think that there are some simple things we can do to make progress beyond this HPI, which is one, the neurological examination, which may reinforce what the patient's saying, but the pattern of weakness, distal or proximal, will help us. The reflexes will help us tremendously. But as you're moving towards the physical exam, I would highly recommend you get some basic tests. One, you never want to miss hypoglycemia causing neurological symptoms, even if they're of a peripheral nature. And you never want to miss hypocalcemia causing neurological symptoms, especially in a patient with perioral numbness. So you might be thinking this is a complex neurological localization when the answer might be a simple electrolyte abnormality. So what I would be doing in real life, I would be proceeding to examine the patient in detail, but asking my nursing colleagues for a quick finger stick and what we have available in our emergency room is a point of care electrolyte panel that results the basic electrolytes in 5 minutes and have both the exam and that electrolyte data available to really push the case forward. There's a lot of other information in the history here reflecting on her sexual history, on the Lyme disease, but I don't think any of those are heavy enough that I would be using them as big weights in the moment before clarifying more what the syndrome is. All right, Navpreet, the mic to you.
I'm loving the discussion, how the case is, you're explaining everything and how you're unfolding the case. So I'll go with the vitals. Patient's temperature is 37.0, blood pressure of 160, heart rate of 120 per minute, respiratory rate of 18, and saturation of 99% on room air. Physical examination, patient is awake, alert, and anxious. He is normocephalic, no trauma to the head. Eyes are clear, no pallor, and extraocular movement is intact. Vision is normal, but patient has difficulty reading fine print. On neck examination, it is supple, non-tender, no cervical lymphadenopathy, and no carotid bruit. Heart examination, normal regular rate rhythm, no murmur, no JVP. Lungs examination normal, bilateral clear lung sounds, no wheezing, no crackle. Abdominal examination is normal, normal bowel sounds, soft, non-tender abdomen, and extremity is normal, no deformity, no edema. On neurological examination, patient is alert, oriented time 3. Patient is dysarthric. Patient has vision. Patient can count finger countings and large fonts, and patient has bilateral hearing loss. Motor strength, lower extremities show the strength of 4 by 5, and upper extremities show strength of 4 by 5. Sensory examination, patient shows hyperesthesia, and gait, patient is had a ataxic gait. Patient is unable to bear weight, and patient has poor finger to nose coordination and dysidokinesia. And I'll stop here.
Wow, and I think the power of the exam is incredibly high. What we're seeing here, I think, on exam is that there is sensory involvement, motor involvement. The sensory involvement is both the skin hyperesthesia, but also the bilateral hearing loss that the patient has. I think if you're trying to understand the difference between dysarthria and aphasia, because you might not observe dysarthria, you might have to conclude the patient has dysarthria. And one helpful thing is to ask, is the patient having difficulty knowing what to say, or is she having difficulty knowing how to say things? And dysarthria is defined as the patient knows what to say, but having difficulty knowing how to say it. And one simple way is to ask yourself, if you put subtitles on what the patient is saying, will it make sense? In a patient with aphasia, if you put subtitles, nothing will make sense because it's a difficulty in knowing what to say. But patients with dysarthria, when you put subtitles on, you'll be able to understand clearly what they're saying. So what is dysarthria? Dysarthria is a more localized problem that begins in the cerebellum and then goes out into the cranial nerves, but also incorporates local issues. All of us have probably had dysarthria because we bit our tongue or had an ulcer on our mouth or had some nasal trauma or went to the dentist. Here, the presence of dysarthria along with the cerebellar signs of ataxia and dysidokinesia strongly support cerebellar disease. So I think we can be confident that this patient has cerebellar issues. And the question is, what else is going on? And the fact that she has weakness and the fact that she has sensory complaints tells us that our localization is a little bit more complex and likely involves both the central nervous system with cerebellar involvement, but also the possibility of peripheral nervous system involvement, given the pattern of the hearing loss. But this could all be a brain stem and a posterior fossa syndrome manifesting in the arms, legs, and in the mouth. And I think a key test that might be helpful here is, I don't know, Navpreet, if you had the reflexes available to you at this point or whether they were not available for interpretation.
Unfortunately, I don't have the
No
reflexes
problem.
answer.
No problem. Yeah, no problem at all. I think it's all the absence of data can just show you how powerful that data might be. But I think here we should try to proceed solving this case without that data, recognizing that it might really be very helpful. So I think we've effectively excluded a brain problem. And I think that everything in between is still fair game, though we've highlighted this prominent cerebellar involvement in this patient. And what remains open to possibility is whether the brainstem is involved, implicating the mouth, the hearing, and the extremity symptoms, or that the patient has a diffuse process affecting almost all her nerves in her body. So I think the localization is cerebellum plus either parallel brainstem disease or diffuse nervous disease. And the reflexes, high reflexes would support involvement in the brainstem, low reflexes would support a diffuse neural disease process. So we know that the cerebellum is involved, and I think it's very helpful to think about cerebellar disease. And whenever you're thinking about cerebellar disease, your first two hypotheses should be that is the cerebellar compressed? Is it under high pressure from a mass or from bleeding or from any space occupying process? That's the first question with cerebellar disease. Or is there a vascular manifestation, namely an ischemic or hemorrhagic stroke? Here, the subacute nature of the syndrome makes a vascular process much less likely. However, it's very, very possible that a compressive disease process is at play, though the bilateral nature of the cerebellar involvement would mean that you would have to have a whopping compressive mass, making that diagnosis a little bit less likely. So after you think about compression and vascular, you should really think, is the cerebellar inflamed or not inflamed? Is this inflammatory cerebellar disease that can happen from a wide variety of infections, autoimmune diseases, or even paraneoplastic conditions? Or is this a non-inflammatory cerebellar disease? And there are many non-inflammatory cerebellar diseases, including those from the effects of toxins like chronic alcohol use, to medications like chemotherapy, to nutritional deficiencies like thiamine, to genetic conditions, many, 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 many. But how do we make progress in this case? I think we have to understand, is this a space-occupying cerebellar disease process, or is this an inflammatory disease process? And the tools to help us will be an MRI with contrast. And in parallel, trying to improve our localization for whether this is the brainstem or the peripheral nerves for everything else involved. In parallel, let's not forget that this person has had 40 pounds of weight loss. So our initial evaluation for causes of weight loss will also probably proceed in parallel. Now, Preet, this is incredibly complicated. I'm really, really excited for your next aliquot. I think hopefully we'll be able to make more progress then.
I'll continue for here from. So for the labs, patient have a WBC count of 9.6, hemoglobin of 16, hematocrit of 44, MCV of 101, RBC count is 4.7, and platelet count of 97K. On CMP, sodium has a sodium of 129, potassium 2.8, chloride 81, and bicarb of 24. BUN is 15 and creatinine is 0.7. Patient glucose level is 83, a 9 gap of 5, albumin 4, total protein count of 6.4, and calcium of 9. On alkaline phosphatase is 50, AST is 26, ALT of 49, and total bilirubin of 1.5. PT-INR is 1.2, T3 TSH within normal range, and parathyroid count within normal range. We have an HbA1c on the patient, it is 5.9, and we did a urine toxicology which came out to be positive for benzos, cannabinoids, and opioids. Beta SCG done, it came out to be negative, and for heavy metal poisoning, lead, arsenic, calcium, copper, all came out to be normal. I'll stop here. And after that, we have two aliquots.
Amazing. Yeah, I think that I think we can make a lot of progress on the possibility of the nature of the weight loss and answer this very simple question. Is this patient having inflammatory or non-inflammatory causes of weight loss? And I think the normal albumin and the normal hemoglobin are strong arguments against a robust inflammatory cause of weight loss, putting us much more likely in that the patient has a non-inflammatory cause of her weight loss. Now, we have to be very, very careful because there are some inflammatory causes of weight loss that we should test for in everybody, no matter what. And that is an HIV test, always. So this patient is missing that test, and also entertain the possibility that the patient has a cancer that is not hypermetabolic, but is unleashing paraneoplastic issues that limit the patient from eating. So could she have a thymoma, for example, that is causing a paraneoplastic neurological syndrome, limiting her ability to eat because she has problems moving her mouth? So I think the inflammatory causes always test for HIV, and don't rule out a small cancer unleashing paraneoplastic devastation. And that's what's causing the weight loss, not the cancer because of its hypercatabolism. And I think, Navpreet, the only signal that we have here, correct me if I'm wrong, or actually there are two signals, because I just want to make sure we heard the data correctly. The MCV is high at 101. The platelet count is low at 97. The sodium is low. The potassium is low. And the urine tox screen was positive for benzos, cannabinoids, and there was one more thing. I'm sorry, I missed that.
Opiates.
Opiates. Okay. All right. So I think that it's hard not to worry in general about the effects of substances like the substance we just heard about, and nutritional intake in patients, especially younger patients. And I think now we can update the medical history to wonder about the possibility that this patient has benzodiazepine use disorder and opiate use disorder, in large part because in large part because of the fact that the patient didn't, in large part wondering why the patient didn't disclose those medications if they're being prescribed, and wondering whether the use disorder, which requires that the patient suffer some kind of consequences, is actually the syndrome that is befalling her right now, including the weight loss. And so I think that when we see that the patient is impacted by these substances, the possibility of nutritional deficiencies, which often accompany a wide variety of substance use disorders, really enters the foray. And then when you layer that hypothesis with a patient having a macrocytic anemia and the thrombocytopenia, B12 deficiency has to scream very, very, very large. B12 deficiency may not be simply because of lack of nutritional intake in a patient with many substance use disorders, but also be the result of two things. One is whippets consumption. So whippets are basically the canned devices that we use to use whipped cream, and they can be filled with nitrous oxide, and nitrous oxide is a known consumer of B12. So patients can get devastating neurological syndromes from whippets use, resulting in B12 deficiency. It's also really important to reflect on the other substance that she has, which is cannabis, and the possibility of cannabinoid hyperemesis syndrome contributing to nausea and poor PO intake. I think it's interesting to reflect on the differential diagnosis of hypokalemia in this patient, but the first thing would be to check on the magnesium level. And because the most common cause of hypokalemia is hypomagnesemia. Hypokalemia is almost always noise in most patients, but can be signal when it's refractory and persistent and severe. So I think most of us would probably replete the potassium and ignore it for now, but if it remains persistently low, engage in a thoughtful differential diagnosis about what it might be. So I think the progress that we would try to make right now in real life is probably keeping neurological imaging in our back pocket, and testing for nutritional deficiencies, and wondering whether we need to scan the patient's chest and abdomen to look for a cancer given her weight loss, and of course, considering an HIV test. All right, Navpreet, the mic is yours.
Thank you, Ravi. I'm loving the discussion. So patient HIV test is negative and B12 level are normal. We got a blood culture for the patient and it does not show any growth. For the celiac disease, we test transglutaminase IgA, IgG, and it came out to be unremarkable. And we did the immunology workup. ANA, C ANCA, and B ANCA, they came out to be negative. For the chest X-ray, came out to be normal. We did a CT head, that is normal. MRI brain and CT spine is within normal range. We did an EKG, and it is a normal rhythm, normal EKG with a sinus tachycardia. And CT abdominal pelvis with contrast show no occult cancer, and it showed no, numerous large and small bowel air fluid levels, suggesting of mild ileus or gastroenteritis. And I'll stop here for the final analysis.
So Naprit, is it true that the next aliquot will reveal the diagnosis? Is that your plan?
Yes, sir.
Amazing. I think it's well, can I ask you just one question? Can you share with us what happened to the patient's potassium and sodium in the hospital? Did she have persistent hypokalemia or did it go away?
It so we assumed that the patient had dehydration, and we gave the patient IV fluids, and all those things improved.
Fascinating. Okay, so um, to summarize for everybody, it sounds like the patient had negative imaging, a negative serological workup, a normal B12 level, and the hypokalemia and the hyponatremia resolved. One final question before we go into breakout rooms. What happened to her MCV and platelet count? Was that also temporary or was that a persistent part of her syndrome?
That was temporary as well. That was because of dehydration, assuming to be a hemoconcentration, and with the IV fluid, it improved.
Amazing. And was that also true of the platelet count as well? Did it also normalize?
Yes, sir.
Okay. Fascinating. So it sounds like the interventions in the hospital were to obtain imaging and serology and to watch these abnormalities fade away with supportive care, but the patient's syndrome remained the same. Is that fair? Okay, terrific. I think we have a good grasp of the kind of issue we have to get to the bottom of. So why don't we go into breakout rooms? Would love for you all to just chat with each other and share some thoughts and try to see what progress you can make by putting your brains together. And I will open them now. We'll come back in maybe 5 minutes or so, okay? All right, welcome back, everybody. I think now our freight has us on the edge of our seats here. I hope you guys had fun, productive conversations and got to know each other very well. And I gotta say, I don't think I don't think that you can kind of spot the diagnosis from a case like this with the data that at least I can't even come close to spotting the diagnosis of the data that we have. So we kind of have to reflect on how we can make progress. And I think in these circumstances where you cannot see a straight shot path to the diagnosis, I recommend that you just kind of paint an arc or what you would a series of events that you would do next. And I think part of that is not having a grasp of the non-cerebellar aspects of this case. What is the fact? What is the significance of the hearing loss? What is the significance of the perioral numbness? And are those things of significance, meaning that did they also just vanish away along with the treatment of just like sodium, potassium, and electrolytes. So it's hard to know. So I think we should just stay anchored to the most concrete aspect of this case, which is the patient has cerebellar disease based on very objective findings of it, and leave the other things as peripheral clues. And so if we go back to sort of our master approach of is it compressive, vascular, or inflammatory? I think the normal MRI makes a compressive cause very unlikely. And it also rules out a large stroke. So I think the fundamental question is, are we dealing with an inflammatory or a non-inflammatory cerebellar disease? And under the realm of inflammatory, I think a lumbar puncture would probably help you make progress and see, is there a pleocytosis in the CSF? Are there oligoclonal bands? And it's hard not to wonder if the patient had Lyme disease in the past, whether she could have neuro-Lyme at this time. And that's certainly a possibility that should be entertained. That's the only infection I can think of that can cause protracted symptoms like this in neurologic in nature. In terms of autoimmune diseases, I think the demyelinating autoimmune diseases like multiple sclerosis would be unlikely in the face of a normal MRI, but a wide variety of antibody-mediated neurological diseases are very much in play. Many of them are paraneoplastic, but many of them are idiopathic, including cerebellar degeneration. You can also get a post-EBV cereballitis, which for this patient, given her age, is another possibility. So that's the inflammatory category. Has she had a recurrence of her Lyme? Does she have an autoimmune condition, an antibody-mediated condition? In the non-inflammatory category, I think when you see the patient's medical history of the substance uses, it's hard not to wonder if there's an occult toxin or a nutritional deficiency. And there are a wide variety of cerebellar toxins that are non-prescribed. The most one that we should know about is bismuth. So when patients take Pepto-Bismol, say to assuage their cannabinoid hyperemesis syndrome, for example, chronic bismuth use can cause a very cryptic, hard to treat cerebellar syndrome. So toxins are certainly at play here. Metabolic conditions, the most important metabolic condition in cerebellar disease to think of is celiac disease. It literally has a name. It's called gluten ataxia. And Kirtan presented it to us on RLR a long time ago and actually stumped us. We did not get the diagnosis. So I'm really glad that that was tested for here. Another important metabolic category is osmotic demyelination syndrome, where patients with fluctuations in their sodium can have a demyelinating cerebellar disease, but that's unlikely in the face of a normal MRI, though MRI is not perfect in that situation. I think nutritional deficiencies are huge and really important to know, and to recognize that B12 level is not enough to rule out B12 deficiency. And a methylmalonic acid is a really, really important next step. So what's on the table for options to think about next is considering a lumbar puncture and sending off a CSF paraneoplastic CSF antibody profile in a Lyme are probably really important considerations. That's the inflammatory category. In the non-inflammatory category, I think sending off a business level or having a conversation with patient about what she's exposed to will be fundamentally important for this case. We already know that she ingested substance that she wasn't comfortable sharing with us on our history. And so opening up that conversation in a patient-centered and safe space is really, really important. So that's where I'm at, Navpreet. Would love to learn from you about how you were thinking about this case and how you ultimately made progress.
Thank you, Ravi. It's an amazing discussion, and all the teaching points that you were telling us were so great. The another teaching point that I learned from this case was whenever we have kind of in a pool where we don't know what is going on with the patient, we always try to rule out the things like infections or like whatever differential we have. We need to rule out those first to get to the final diagnosis. And so we did this with this patient as well. So we did a CSF tap on this patient. Uh, After the tap, there was WBC count was normal. There was no WBC count. Oligoconal band were negative, and we did the whole infectious workup on the CSF, Lyme negative, HIV, RPR, VDRL, everything came out to be negative. CSF examination showed us elevated proteins with high albumin index, along with albuminocytological dissociation. So we assumed the patient of chronic inflammatory demyelinating polyradiculoneuropathy, and we started the patient on intravenous immunoglobulins for 4 days. And after starting the patient on the globulins, her motor symptoms improved, paresthesia improved, speech and hearing and vision improved, and her appetite also improved. So the final diagnosis for this patient is chronic inflammatory demyelinating polyradiculoneuropathy.
Amazing, absolutely amazing case. Very, very enlightening, and goes to show you how powerful the lumbar puncture is in this case. I'm curious now, Preet, how were you merging the findings for cerebellar disease that you had with this diagnosis? How are you linking those two?
So uh, uh, I don't have an exact answer for that as well. The Along with that, I just want to give a shout out to Dr. Ravi who helped me prepare this case. Uh,
Amazing.
Chronic. When I was reading through the information, we usually don't have any triggers for chronic inflammatory demyelinating syndrome. Because most of the time, if we can like a differential should be GBS, Guillain-Barré syndrome, and they usually have a trigger for the neuropathy. But with the chronic, we don't have any neuropathy, but the patient have symptoms of sensory and cerebellar and motor weakness. So after ruling out all the other syndromes, that is where we reach out to the final diagnosis.
Fascinating. It's so, so intriguing. I think if you go back to the original conversation about what the other disease aspect is it brainstem or is it a diffuse nerve process? I think that you're seeing it play out more that it's a diffuse nerve process. And I think that CIDP is a great example of having a demyelinating polyradiculoneuropathy of the entire neuroaxis, all the way from her nerves supplying her ears, her mouth, to her legs. Really, really interesting and fascinating case. Yeah, I learned a lot. I'm so glad that and she got a lot better. I see Leah's asking what are the reflexes. I think that the reflexes would typically be reduced in patients with CIDP. Um, and the difference ultimately between AIDP and CIDP is the duration, with AIDP being less than 4 weeks until uh, um, nadir until less than 4 weeks, and CIDP being more prolonged than that. That's really, really cool, Navpreet. Thank you so much for sharing that. I'm curious if there's any other learning points that you wanted to emphasize before we learn from Tansu.
The other important points, if I would add, would be, as I discussed before, like a GBS should be one of the common differential that come across with this kind of case. And that duration, as you discussed already, it should be less than 4 weeks. And then there should be always a trigger, whether being a GI infection or some vaccination. And if that is not the case, then we can think on the lines of CIDP.
Amazing. That's such a great, powerful, and very simple takeaway. Thank you so much for putting it together. All right, Tansu, the mic is yours.
Thank you so much. What a case. What a great discussion, Ravi. So I hope I was able to capture the most important points. Please correct me if I have any mistakes here. So we had a 26-year-old female patient who came with bilateral lower and upper extremity weakness. And when we hear about weakness, we have to first clarify whether this weakness is a sense of fatigue or a reduction in energy, which could be defined as asthenia. And in asthenia, there would be no focal or sensory symptoms, and there would be presence of anorexia. Or is this dropping objects or patient dropping herself? Which could be pointing towards a neurological problem. So in differentiating asthenia and neurological problems, we use focality, accompanying sensory, autonomic, or cognitive symptoms, and presence or absence of anorexia. And exam is the gold standard, and respiratory involvement could be used as a proxy to understand if this is a neurologic problem. Inability to walk points to a neurological dimension in patient's history, and the body mass reduction points towards asthenia. And so we see that there could be both neurologic and asthenic component in this patient's case. And so we ask, is the weight loss secondary to an inflammatory process or a non-inflammatory process? And in inflammatory category, we have infections and malignancy and so on. And non-inflammatory category, we have no access to food, malnourishment, malabsorption, medications, etc. And so as Navpreet gave us more information about the physical exam, we heard that there's a positive sensory component in this patient, which makes myopathy and postsynaptic NMJ involvement less likely, and absence of cognitive symptoms in this patient makes brain less likely. And then no change in reflexes, urinary and bowel symptoms makes myelopathy less likely. So we are thinking, could this patient have presynaptic neuromuscular junction problem? But we have to rule out hypoglycemia and hypocalcemia because these issues can mimic neurologic problems. So first we need to rule out hypoglycemia and hypocalcemia. The patient had dysarthria and cerebellar signs, so we saw there is a prominent cerebellar component to her disease, and but we should also not rule out the involvement of brainstem, posterior fossa, and diffuse neurologic processes. Those are still in question. If the reflexes are low, that could point us towards a diffuse process. And cerebellum involvement is possible through couple mechanisms and space-occupying mass lesions, vascular problems, both in the form of ischemic and hemorrhagic, and inflammatory problems could be affecting the cerebellum. So we have to get a MRI with contrast, improve the localization of symptoms, and still investigate the causes of weight loss. In this patient, since she had a normal albumin and a normal hemoglobin, these decrease the probability of inflammatory causes, but we should still test for HIV and do not forget the paraneoplastic causes secondary to a small occult malignancy. We heard from Navpreet that the patient had a positive UTOX for benzo and opioids, which she didn't disclose during the history, during she was giving us her history. And these could be the reason for why our patient had the symptoms that she had. And she also had it appeared as if she had macrocytic anemia, in which case we needed to check the B12 levels. Nitric oxide in canned whipped cream could also decrease the B12 levels. We shouldn't forget about that. And patients' use of cannabis also makes us think the cannabinoid hyperemesis syndrome. We should also check magnesium levels because it's a very common cause of hypokalemia, which we saw in this patient as well. And we should scan the chest and abdomen for malignancy. And then we saw that the patient had negative imaging, negative serology, normal B12 levels, hypokalemia and hyponatremia, also MCV and platelet counts resolved with supportive treatment. They all normalized. So we know that the MRI could rule out compressive mass or a large stroke, but since we got a negative MRI, then it made the compressive mass or a large stroke very unlikely. And what we had as like most prominent components of this patient's manifestations were perioral numbness and hearing loss. So, and her MRI was negative. So we started thinking about inflammatory antibody-mediated autoimmune diseases, post-EBV cerebellitis, or the patient's history of Lyme made us think of post-Lyme neurologic involvement, or substance use, occult toxins, and bismuth, which could present as a cryptic, hard-to-treat cerebellar syndrome. So we decided that we should get an LP and analyze the CSF antibody profile, also check the Lyme antibodies and check bismuth level. And in the end, the CSF analysis through the LP revealed elevated proteins and albuminocytologic dissociation, which pointed us towards the final diagnosis of chronic inflammatory demyelinating polyradiculopathy. And that's all from me.
Oh my gosh, Tansu, do you still have any air left? I can't believe you're not short of breath after that master class. Oh my gosh, that was amazing. I can't believe you captured everything. It was literally like a sponge and organized it and reflected it back in such a clear and easy to follow manner. I don't know if you've had a chance to look at the chat, but you probably should before we go of all the people. The chat is literally on fire. Anywho, happy Friday, all. Thank you, Navpreet, for an incredible journey, a really, really educational case. We learn a lot. And thank you to Gerardo for scribing a really, really complex case, and to Tansu for wonderful teaching points. All right, all. We'll see you next time. Have a great day. Bye.